Okay, good afternoon, everyone. As I said, my name is Paul Hunstead. I'm the Improvement Lead on the Paediatric Program, the Clinical Excellence Commission. I'm a paediatric nurse by background, and I still spend part of my week working at Sydney Children's Hospital in the emergency department. I thought we'd just go through just some housekeeping to start with. This webinar will be recorded, so please ensure that your microphone is on mute and your camera is turned off. I'm sure that this will generate some great discussion. However, I'm just going to wait until the end of the presentation for questions. So I'd ask you if you could please add any of your questions to the chat function. For those of you who are not familiar with using Teams, the chat function is just located at the top banner bar, and it looks a little bit like a thought bubble or a conversation bubble. It's just next to the image of the hand. So I'd like to acknowledge the traditional owners and custodians of the various lands on which we all are working today, and the Aboriginal and Torres Strait Islander people who are participating in this virtual webinar. I also pay my respects to elders past, present and emerging, and recognise and celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the lands and waters of New South Wales, which we all are meeting today. So we've got three presenters here this afternoon. The first is Dr. Elizabeth Cotterell. Liz is a fabulous and well-respected paediatrician. In fact, we've shared many experiences of managing kids requiring intraosseous needles in her days when she was working at Sydney Kids Emergency Department. That was, of course, before she moved up to Armidale. Liz is a senior staff specialist paediatrician and clinical director of paediatrics up in Armidale. She's also the Associate Professor at the School of Rural Medicine at the University of New England in Armidale. Liz is going to be talking about some of the lessons on intraosseous sample interpretation from the case highlighted in a recent Paediatric Watch. The second speaker is Dr. Tina Yen. Tina's the Director, Department of Clinical Chemistry at St George Hospital. And Tina is going to share with us the science behind intraosseous samples and why they're not suitable for point-of-care testing devices. And she's a wealth of knowledge in clinical chemistry. And last but of course not least is Amy Sutherland. Amy is the point-of-care testing clinical training coordinator for New South Wales Health Pathology. She's a wealth of knowledge on all things point-of-care testing, and she'll be talking about some alternatives to intraosseous samples. And also share some practical tips and tricks on obtaining venipuncture or capillary samples on the shutdown child or infant who may be critically unwell or injured, who may present to your ward or unit or department. So firstly, I'd like to thank New South Wales Health Pathology. This has been a really valuable and worthwhile collaboration with New South Wales Pathology. And I guess it's worthwhile talking about the catalyst to actually putting these webinars together really came from a Paediatric Watch newsletter that was distributed a few months back that provided some clinicians some guidance, I guess, on the use of intraosseous samples via point-of-care testing devices. We know that IO insertion is often associated with a pretty stressful scenario or situation. It's one of those procedures most of us know how to perform. However, thankfully, it's not something we have to do on a regular basis. I guess as the author of that Paediatric Watch newsletter, it highlighted, I guess, not only my own ignorance, but also brought to light, I guess, a misconception that was shared by, we've since realised, many clinicians on intraosseous testing and interpretation. So at this point, I will hand over to Liz to tell about a patient story. Over to you, Liz.
Okay, so the case... Can you hear me?
I can.
You can, okay. So the case centres around an 11-month-old boy. He had a background history of complex medical disorders and had been managed with a regional hospital as well as rural hospital where the family were actually living. He presented in the early hours of one morning to a rural district hospital where there was a doctor on duty, and he had presented with a 2-day history of increasing gastrointestinal losses, both from the bowel as loose stools and vomiting. It was very obvious to the nursing staff who assessed him, as well as the doctor who was quickly called to see him, that he was a very unwell boy who was mottled, lethargic, febrile and tachycardic at presentation. The priorities for resuscitation were immediately obvious, and it was recognised there was going to be difficulty with the intravenous access. And despite seeking some assistance from an anaesthetic registrar to gain IV access, they quickly escalated to inserting an intraosseous needle to get vascular access for volume resuscitation with the fluid bolus. When the intraosseous needle was inserted, some marrow was collected, and this particular rural hospital had an on-call pathology service available who was able to process the samples. So point of care testing wasn't done on the initial sample, it was sent to the pathology lab for the initial bloods that were taken. Next slide, Paul. So the IO sample, the results were available a little bit later, but they were taken at the time that initial resuscitation was commenced, when the child was given both a fluid bolus of saline as well as 10% glucose. The doctor who was at the rural hospital contacted the local paediatric service for assistance and actually asked for them to contact NETS for escalation for retrieval and ongoing support for resuscitation of this very unwell child. The discussion that subsequently resulted around stabilisation of this infant recognised the difficulties with IO access, but also that a retrieval team wasn't immediately available to transfer this child. The results that came available from the IO sample were discussed during the consultation, but the initial thoughts were that they weren't really going to be valid because they were from an IO sample. So they weren't actioned or recognised as being valid and impacting on the immediate care of the child at the time. Subsequently, he was transferred by road ambulance with the doctor as a medical escort, as it was deemed that was the only suitable option to be able to escalate for a higher level of care, given the logistics of a retrieval team not being available immediately. Unfortunately, just prior to transfer, the intraosseous needle fell out and the decision was made not to replace because there was some clinical improvement in the child's condition after the initial fluid boluses. The child by now was, after a 90-minute transfer time from the rural hospital to the regional hospital, was now getting on to more than 5 hours from the initial time of presentation to the rural hospital. Care was handed over from the GP, who escorted the child to the paediatrician in the emergency department. And the next few hours really focused on ongoing stabilisation, which focused primarily around IV access. At the regional hospital, an anaesthetist was called to assist with IV access using ultrasound, but was still exceedingly difficult. A femoral venous stab was successful in getting another blood sample, but unfortunately intravenous access wasn't still obtained, but ongoing rehydration was provided through nasogastric tube. And antibiotics were given given the lack of IV access. So the first sample from the initial resuscitation that was available was a femoral venous sample that did demonstrate hyperkalemia as well as evidence of an acute kidney injury and hypoglycemia. The child was subsequently transferred to the ward for ongoing management and deteriorated further and progressed on to a cardiorespiratory arrest on the ward. Next slide, Paul. Initial resuscitation on transfer to the ward had consisted of oxygen and glucagon for the low glucose, but during the resuscitation, that occurred after the child was on the ward. Further IO access was gained initially for resuscitation, and then a femoral line, central venous femoral line, was able to be inserted. So during the resuscitation, there was further samples that were taken via various routes, including arterial, capillary, and venous at various stages in the ongoing resuscitation of this child. And they clearly demonstrated significant hyperkalemia, as well as evidence of acute renal failure. The child was subsequently retrieved to a tertiary referral hospital, and unfortunately there was evidence of an acute hypoxic brain injury, and a decision was made for withdrawal of care, and the child passed away the following day. Yes, so next slide, Paul. So as a result of the outcome of this case, there was a root cause analysis which had many recommendations around escalation and transport. So the main ones that we're focusing on for this webinar that were highlighted in the Paediatric Watch that Paul mentioned were around interpretation of intraosseous samples. One of the recommendations of the RCA was about intraosseous sampling and use of point of care testing as part of emergency management. And this led to us having a discussion with our local pathology service that pointed to this notice that was released in 2019 that gave very strict recommendations around point of care testing and intraosseous samples not being seen as valid, and a recommendation strongly against use of IO sampling for point of care testing, and that the focus for IO access is primarily for resuscitation and fluid treatment rather than for sampling and pathology testing. So at that point, I'll hand over to Tina.
Thanks, Liz. And hi, my name's Tina Yen. I'm a chemical pathologist and I represent New South Wales Health Pathology here. And just reiterating Liz's last slide, there is a policy, and the policy says that you cannot use intraosseous samples for laboratory analysis across the board.
And we just summarise the issue here with intraosseous samples. The current policy is that you cannot analyse intraosseous blood on any device, either in the lab, in the hospital, or on one of those point of care devices. That is the standard pathology policy. And the reasoning for this is shown in this diagram. It's because the instrumentation is not suitable to give results on these samples. So even if you do manage to get some sort of readout on one of these handheld devices, you must be aware that may be actually invalid. And at this current time, New South Wales Health Pathology will not stand behind any results that are obtained on intraosseous blood or on one of these devices, because we have not been able to ascertain their quality for clinical use. That's the actual situation, but we just want to go into a little bit more detail so that you have a bit of an understanding about this decision. Yes, so this is one of the devices. It's a little gun, and it's actually much more straightforward these days to get that into the bone and into the bone marrow. Sometimes the device is accompanied by a package insert, and this is an old version, but people who open these packages, especially pre-packaged in a small community service, might find that there's a little insert and it says, following lab values have shown mixed results, but you may use these results from the blood that you collect. So this is a bit of a problem because this is issued by the company, and this is where we have this contradiction. So just wanted to highlight that for anybody who, like the GPs or the VMOs who actually have one of these or open one of these packets. So if we go on, the whole problem revolves around how the fact that intraosseous blood samples are just really not acceptable in terms of the quality for standard laboratory analysis. There have been a number of publications, and a lot of these are performed using well patients, so therefore it doesn't replicate the actual complexity of trying to achieve testing under very stressful and limited situations. And so therefore the validity of papers that say, yes, you can use intraosseous blood testing, the validity of those results has to be questioned. There are a number of issues related to the intraosseous samples, one being that they are very thick and contain both adipose tissue and sometimes bone fragments, so they actually cause physical problems. They can clot the tubing that we have on our blood gas analyzers, like the big machines that we have in hospitals, as well as the little handheld devices. So there's actually a physical issue with these samples. And secondly, they are almost always hemolyzed, so that impacts on their analysis. So moving on, I'm just showing you here an example. So we have intraosseous blood that was collected at Sutherland Hospital, and the blood, this was processed in the laboratory under as good a condition as you can with our supervision. And on the left, you can see that is what the colour of the serum. So it was very clear, but it was quite hemolyzed. So under the best handling, we still had a very, very hemolyzed sample. And on the right, the clear yellow is what it should look like. So that's the level of red cell hemolysis. And in this patient, when it's a hemolyzed sample, we are limited to only providing certain numbers, certain values, and that's of all the tests that were requested, that is all that we're able to issue. So even the best that you do, there's still a limitation to what you can actually achieve from a sample that is as hemolyzed as this. Yes, so here are a couple of papers that are probably the most useful references right at the moment because they're fairly recent. Now, the references that we have in this presentation will be available through a link, so you can access the actual data that we show. But what I am just going to go through very quickly is just some of the data, because this will help explain some of the variation. So just going on to the first couple, one of these studies was the Scandinavian Journal of Trauma and Resuscitation in Emergency Medicine 2017. Again, they used healthy volunteers, but this was the way to do the analysis, and they compared intraosseous with arterial samples. And what you will see in the graphs coming up are how the individual tests compare. Now, these charts, if you just look at the charts on the left, it's Bland-Altman plot, and basically if you look at the top, the x-axis represents the concentration along from left to right, 125 to 140 millimole. On the y-axis, you see the difference between the intraosseous and the arterial. So the magnitude of how different they are. At the top, you'll see it's 0. So 0 being 0 difference between them. And then as it goes down, increasing differences between the results. And so for the sodium, you can see that they were quite different. And that's more clearly exemplified on the right, which summarizes the difference. So you'll see the two samples, which are intraosseous values for the sodium, and how they compare to the right, which was the arterial sample. So you've got a consistently low sodium there compared to the arterial. So you can see there are not reasonable patterns. There is a correlation, but the relationship between the actual intraosseous and the real value, for example, in that potassium, it can vary. So we can't actually predict the error that you could use to accommodate an intraosseous blood result to estimate what the arterial or the venous would be. If we just keep going on, just wanting to show you how the different analytes performed. And overall, you can see why this is complex. Some things don't look too bad, and some things look really quite haphazard. and the inability of us to control the situation or to have any controls over the quality of that intraosseous sample mean that we can find it very hard to give a reasonable estimate of what the true result is, as it would be compared to a venous sample. Next slide. Hemoglobin and hematocrit. This study actually found that the variation was probably reasonably acceptable, which is quite good. However, other papers have actually said you must not use hemoglobin collected by intraosseous samples. So it's just important that, you know, reading one paper and then reading a different paper will give you contradictory evidence, and it is very complicated. The haematologists in New South Wales Health Pathology have stated that they do not want hemoglobin on intraosseous samples measured or interpreted. So, so summarising the overall evidence, which is that intraosseous route is vitally important as a last resort, because you need to infuse fluids and you need to start treatment straight away. Intraosseous samples have not been considered, intraosseous route is not considered a way to extract blood for testing. So testing was never the purpose. However, now we do try to do testing, and these results should always be interpreted with caution. There isn't enough scientific evidence regarding the validity of the tests, and we're in an unstable situation. And there's certainly the important variables cannot be used for decision making. And the next slide. This is another study from a bit earlier, but again, showing that, well, definitely white cell count and platelets were not correlated. And then you've got some things that are correlated and some things that are not correlated. So you can see that you will get contradictory evidence, but not only that, you'll get half of the biochemistry panel reported and half not. So that also contributes to stress and confusion all around, because some things are acceptable, some things aren't. So just moving on. So, you know, some people say that, you know, because it's correlated, then we can use it, and we can just accommodate, we can just factor in or factor up or factor down, and that's always a little bit risky. Because of this dilemma and the quandary that this statement from New South Wales Health Pathology poses, where we do not allow this testing, nor do we allow the reporting of results because we're concerned about misinterpretation. We realise that this is really not going to be very supportive of our clinical colleagues. So is there something that we can offer? And after a lot of consideration, we have made some suggestions, which we will go on. Jamie will go on to present, which will address some of the concerns, but it's a subject that's open for further discussion later on. So we might hand over to Amy at this point.
Thanks, Tina. Yeah, so hi everyone, my name's Amy. I am the Clinical Training Coordinator for Point of Care, and I am also a registered nurse with a background in rural and remote. So this case study did really hit home for me. I could really understand it. And so when I was looking at what other options I was going to discuss, I have kept in mind like the target audience here in relation to the case study. So the two things that I'm going to focus on are your capillary sampling, and I will touch a little bit on venipuncture as well, because as you know, when you've only got IO access, these are probably the next things that you're going to be looking at. So if we were to look at capillary sampling first, as we've highlighted, Tina's just highlighted, it can be used on our point of care devices. So this is anywhere from your neonates, your peds, up to your really crook adults. You can use this option. A couple of things to keep in mind is there are no reference ranges at this point in time for capillary sampling. And the other thing I think we have to highlight here is if you own an iStat, you would be quite familiar with Chem 8 cartridges. So if you do have Chem 8 cartridges, please just be aware that we cannot use these on our iStats for capillary sampling at this point of time. So this happened to us back in February 2020. I want to reassure you that this wasn't just a New South Wales issue, it was a global issue. It is temporary. We are hoping that this will be fixed and we will be able to resume it in the next 12 to 24 months. The other thing is that in the interim, we do have other cartridges available that can cover those analytes that you are going to miss on your Chem 8 cartridge. So if this is something that you feel strongly for your department that you do want, I'm really urging you to get in contact with us at point of care. Get in contact with your point of care coordinator because we can help you out and give you some other cartridges to use in the interim. All right, so there are two locations that you can do your capillary sampling from. So it's going to be either from the fingers or from the heels. It's going to be a heel stick. So I'm just going to quickly touch on your fingers first. So with fingers, it is acceptable for your adults and your older kiddies, but we're not going to be using it on our newborns and our infants under 6 months of age. If we're looking at those guys, we're going to be going for a heel stick. Some people get a little bit nervous because they feel that there is that bit of a grey area there. So a general rule of thumb is if you do have an infant that is over 10 kilos, you can be going to your fingers over your heels. But yeah, so that decision for you guys is going to be based on the weight of your kitty. It's important to also mention here that your lancet depth is really important. And I will touch on this a little bit further down. But it's really good to get a bit more of a knowledge about the lancets that you have available in your facility for capillary sampling and for testing on a number of patients from a number of different ages, because it does cause quite a bit of impact. So with your finger samples, you are going to be using the middle and the ring finger. So there we have them there. The reason we're avoiding the other fingers, your index finger and your thumb actually have an artery that we would like to avoid, and your finger obviously is just a little bit too small. So a few things when you're going for the fingers. In the picture there, you can see highlighted in the green shaded bits are the bits that you're going to target. That's kind of the thickest, fleshiest bit where you want to take your sample from. So of course it's going to be the palmar surface, middle or ring finger, slightly off center in that fleshy part. Follow your manufacturer's instructions. And I've got some slides here down at the bottom. Sorry, some dot points here down at the bottom. If we just get those up, Paul, beautiful. I have mentioned here that you should be trying to make your punches with your lancets perpendicular to the fingerprints. So across the fingerprints and not in the same direction as your fingerprints. The reason for that is simply because when you go in the same direction as your fingerprints, you're going to find it a lot harder to get that drop of blood, and it could very easily run down the grooves of those fingerprints. Now, a few people are still confused a little bit on that, so I have popped a little picture a bit further down to explain that if any of you are sitting there a bit confused. All right, next slide. Okay, so our heels. So of course, this is our little ones. This is our neonates, our pediatric patients less than 6 months. Of course, lancet depth and site selection is very important, and the use of an incorrect site for a heel stick, we can be causing injury to nerves, tendons, cartilage, all those types of things. So if we go to the next slide. Yep. Here's where we want to be, the sites we want to be looking at. So same as the last slides, we're looking at those green shaded areas on this bubby's foot. So if you're going for a medial lancet prick, you want to measure from kind of the middle of the big toe, and you want to make a line down to the base of the heel, and you want to be going in that green shaded area. If you're going for a lateral heel prick, you're between the 4th and 5th toe, line down, and then you're going in that green shaded area.
I did just pop that little table in there as well, just to show you that there is a lot of evidence out there that and a lot of studies that have been done to determine the optimal depth. And next slide, because we'll have a bit of a chat about the lancets. Yep, a few things about the lancets I just want to bring up before we go into our equipment in a bit more depth, and particularly in the point of care space. Your lancets have been really specifically designed first and foremost with the triggering of the lancet taken into account. So I know I've been guilty of this, of really pushing down on the skin. You're actually going to cause more harm, and you could potentially, I guess, stab your patient further than you want to. When these lancets are made, they're made with that triggering and that pressure on the skin taken into account. So when we ultimately push a little bit harder than we should, we're going to decrease the depth, and that can become a bit of a risk. The other thing is there are two different ways that lancets strike the skin. You're going to have your ones that pierce the skin, and you're going to have your ones that actually cut the skin. So it's really important to know which type of lancet you're dealing with. And then you really need to know the depths of your lancet. So for example, in point of care, we use the purple ones that you're seeing on the screen now, and they've got a depth variance. So you're looking at a low depth of 1.3, a medium depth of 1.8, and a high depth of 2.3 in those. Your tenderfoots, you won't see so much in rural and remote space. That probably is more for specialised areas, and they come in a variety of different depths for your really little bubs. And then in the top right-hand corner, you're going to see what's called a mini vet. These are really, really great little tools for collecting capillary samples for use in the iStat. A couple of rules with them: they have to be full when you're going to get your sample. It is heparinized, that mini vet is heparinized, and a full mini vet will give you 1 cartridge. Down the bottom, in the bottom right hand corner, something you might be more familiar with is like the capillary straws or the capillary tubes. Again, same rules apply. You've got to get those pretty much full. Up to 90% is really good for those. We do still see these used on the iStats as well, but to be quite honest, I'm quite a fan of the mini vets. The capillary tubes we will see used more in our ABLs and our GEM analyzers. Okay, so some clinical considerations. This stuff you're all aware of. We need to clean the skin. The cleaning of the skin is just done with your 70% isoprolol wipes. Let it dry. The warming of the skin. Now, this is quite an interesting topic here. So, of course, the warmer the skin is, the better sample you're going to get. A nice warm foot or finger that's a capillary sample is considered like an arterialized sample. But if we're looking back at this case study, I think it's fair to consider that you might not, having a warm foot or a warm finger might not be an option, because this is a very crook, very shut down kitty. And that's for your clinical discretion. Like, what is more important to you right now? Popping that IO in, resussing this child with fluids, and then getting some better access, some venous access? Or do you really want the gases now and the point of care results now, and taking all that into consideration? Also taking the clinical needs of your patient into account, of course, because they're at the forefront at the end of the day in all of this. So positioning, comfort, having them as settled as possible, those types of things. Okay, so with your technique, you do just want to create intermittent, gentle pressure. When you start excessively squeezing and really trying to push that blood to the surface in a capillary sample, if you're doing it excessively, you're going to cause hemolysis. You can potentially contaminate your specimen with tissue fluids, and all of this is going to alter your results. The other thing we want you to do is just always make sure you wipe away that first drop of blood before you collect. That first drop of blood is clearly going to be a little bit contaminated, so we want to decrease that risk as much as we can. So in terms of for those of you who might have been a little bit confused about my previous statement, I hope this clears it up for you. So if you do have a lancet that's going to cause like a slice more than a puncture, this is just a really good tip to give you that nice big bead of blood. So in the first picture, you can see that little line is moving in the kind of the same direction as the fingerprints. So ultimately the blood's going to come out and it's just going to run down those grooves. In the second one, that line is going across multiple fingerprints. What that's ultimately going to do is create a nice big bead of blood, kind of like what, and ideally what we see in that little picture there on the left. Okay, so just quickly on venipuncture on the next slide. I think it's coming, Paul.
Sorry, I've gone through. It's just taking a while.
No, you're right. Okay, so with venipuncture, again, your decision is going to be largely based on the clinical picture that you're seeing in front of you. Your facility, your resources, and your skill mix are really going to contribute to whether you're going to use this option. We've got with our bubbies, the most common things that we're going to be using for venipuncture are your butterfly collection sets. That's kind of the middle picture there. We see the neo-safes used in more specialized areas as well for pathology collection. It ultimately just looks like a butterfly, except there's no tubing on the end and it lets the blood just drop into tubes. And this is where I really want to highlight that for point of care, we must be using our heparinized syringes on our devices. Clinical considerations are again much the same as what I just highlighted in the previous slides, but again I really want to emphasize how with our heparinized syringes for point of care we need to be having them at least half full to give us a good quality sample. So for example, if you're working with a 1 ml heparinized syringe, we want you to have at least 0.5 mils of sample in that syringe. What ends up happening if you go less than that, you end up with way too much heparin in too small of a sample, and that can be altering your results as well. The last thing that I just wanted to show you is the educator in me always likes to leave a little bit of a hint and a tip for any of you that want to go out there and start training your staff on technique. I find that doing things like these in controlled environments with your staff can really help to reduce anxiety in situations like with this case study because they're already familiar at least with the technique. So what I've been doing with staff when I go out and do point of care training is I grab some food dyes, I grab the capillary tubes and also our mini vets, and I grab just there you can see I've just got a chapstick, anything that's going to create a hydrophobic surface. So I take my bluey and I just rub some of the chapstick onto the bluey, and then I'm popping some big drops of the dye onto that hydrophobic surface to create those big blobs of blood, so to speak. Then I get the staff to pick up the capillary tubes and the mini vets, whatever is familiar in their facility, and we literally just sit there and I get them to practice. They will soon, through trial and error, figure out the most appropriate technique. Obviously, I'm there to give them a few different hints, but I find a lot of it they figure out themselves through trial and error, and they'll soon realise how to collect a really good sample efficiently. Okay, that's about it from me, so I'll hand it back to you, Paul.
Great, thanks, Amy. That was fantastic, and thanks to all of our presenters this afternoon. Just very quickly, we are going to send out an evaluation on the webinar, which will both be included in the link in the chat, and you'll also be emailed that link as well. And that's really for us to better understand what you liked, potentially what we can do to improve, and other things, whether or not a one-page summary, for example, a frequently asked question would be valuable. And also, if this is a useful way of disseminating information, whether or not there are other topics that you would like us to present. Now, if you notice in that the link as well in the chat room, I noticed Sarah's put a link to a number of those things, including Amy's useful resources, some of Tina's papers that she discussed earlier, and also some of the tips and tricks, but also the how to contact your local point of care testing coordinator. Now, I did notice there was a question that came up in the chat that Dan had asked. I think it's probably for you, Amy, around specifically what do you mean by along the fingerprint and not down.
Yeah, it's a little bit confusing, but I don't know if you can actually see me, but if you look at the fingerprints on your fingers, and you don't want to, I guess, create a cut or a finger prick, so to speak, that goes in the same direction as the way that fingerprint is traveling, because ultimately the blood's going to just travel down in between those grooves and make it a little bit more tricky to get your sample. If you can kind of cut along those fingerprints, you will find that you will get a much better sample. I find what helps too is to know what type of lancet you're using, because some lancets in facilities have literally do slice the finger open, I guess, so to speak, and create that bleed, whereas others are a puncher. But ultimately what we're trying to achieve is to stop that blood running down the grooves between the fingerprints, and it's going to do that if we say cut in that same direction as the way your natural fingerprint travels.
Thanks, Amy. And there's just, we're nearly up with our time, but Tracy's asked, would love ordering details for mini vets. So I'm sure that we can include that in the information that we distribute as well. And I guess just emphasising what Amy had said around, if you do have any questions, there are a number of experts that can help support local sites. So contact those point of care testing device educators as well. I think we've got time for just perhaps one last question, and that's from Joanne. Can the IO sample be analysed in the lab rather than point of care? I might hand that over to Tina.
Thanks for that. Look, it's a good question. In general, they won't be able to be analysed in the lab, but it is possible that the lab can contact the on-call pathologist, and the pathologist can authorise the lab to go through the special procedures that they need to go through, mainly that the sample has to be spun down to sediment any bone fragments, any tissue, and the cellular component, to make it as clean as possible. The sample that we had at St George, we actually had to spin down a couple of times, which is quite unusual. So yes, in some situations, especially with the hospital type based samples, the lab can definitely reach one of us, even if it's out of hours or on the weekend, to get authorization for that testing. But in general, we are more concerned with emergency departments where they might try to put a sample through and they haven't notified anyone from the lab, or if you've got one of those handheld devices and you're quite remote and you try to analyse it then, and you might get a false result.
Thanks, Tina. I think our time is up. If you do have any more questions, feel free to contact myself at the CEC, and I'll ensure that the questions get answered by those experts that we've had. I'd just like to take the opportunity to thank our presenters, Liz, Tina, and Amy, and of course also thank the CEC team for making this run very, very smoothly this afternoon. So thanks everyone for joining us. Enjoy the rest of your afternoon, and have a good weekend.